Hi, my name is Sharon Sam. I'm the infectious disease pharmacist for the Sinai Infectious Disease Clinic, and I'm accompanied today by Christopher Patrone, who he'll talk in a few minutes. And today we'll be presenting about our clinic and what our services we provide here at Mount Sinai Hospital as well as Holy Cross Hospital. So the Sinai Infectious Disease Center provides medical care and multidisciplinary wraparound support services to patients living with HIV, hepatitis C, as well as high-risk HIV-negative patients. Our infectious disease services are provided both on the inpatient and outpatient side. Our physicians round specifically at Mount Sinai Hospital on the inpatient unit. They also manage the outpatient clinic that's located here at Mount Sinai Hospital at the Schwab Rehab Clinic. Holy Cross also has their own infectious disease physician, Dr. SIDC, who also rounds on the inpatient side at Holy Cross. This is the Schwab Rehab Hospital that's located on the corner of California and Ogden. Again, our outpatient infectious disease clinic for both Holy Cross and Mount Sinai Hospital are located in this building on the first floor. These are our three infectious disease physicians. From left to right is Dr. Lisa Russell, Dr. Nancy Glick, and Dr. Sunita Mohapatra. Again, they round on the inpatient side for infectious diseases at Mount Sinai Hospital, as well as manage our outpatient ID clinic. This is our infectious disease nurse practitioner, Sarah Argentine, who also rounds on the inpatient side at Mount Sinai Hospital and has a half-a-day clinic once a week in our outpatient clinic. This is our infectious disease clinic staff. Laura Rodriguez is our clinic receptionist. She's the one responsible for making all the infectious disease appointments for our patients, as well as registering them during their appointments and verifying insurance. And then Jill McNeil is our medical assistant who triages the patients, takes vitals, and does their blood work. This is our pharmacy team. This is me, Sharon Mew. I'm the pharmacist for the ID clinic, and then Tonya Williams is our pharmacy liaison. At Mount Sinai Hospital, our HIV navigators are Teresa and Debbie. Christopher, which you'll meet in the next couple slides, is our navigator for hepatitis C, and Rich is our navigator for PrEP or HIV prevention. Most of you will often see Teresa Gonzalez on the floors, our early interventional specialist. Any patients that are newly diagnosed or established diagnosis with HIV, she meets at bedside. She does assessments to navigate what their barriers have been to linkage to care or follow-up, or even treatments such as insurance, food pantry, transportation, behavioral health, and she makes those referrals to our case managers, which I'll talk about in the next slide. Christopher Patrone does a similar role as Teresa on the units, but for our hepatitis C positive patients. We also have patient navigators at Holy Cross, Robin and Tamisha, who meet the patients at bedside not only for HIV and hepatitis C, but also for PrEP. Our case managers for HIV are Ivan, Eric, Amar, Rich, and Yesenia. So after the referrals are made by Teresa, our early interventional specialist for navigation, she then refers them to the case managers who assist patients with any supportive services that are barriers to following up in the clinic with the physicians or barriers to medication therapy. So that could be housing, transportation, food, rental assistance, dental referrals, mental health. So these are all support services that are provided by our in-depth case managers. We also have our mental health specialist, Jacqueline Frankie, who collaborates with Sinai's Behavioral Health Department. She links our patients to their mental health appointments, whether it's for psychotherapy or for a psychiatrist appointment. She also provides support groups outside of the Sinai hospital as well as our department. This is an outlet for HIV patients to channel their diagnosis, whether it's through art therapy, yoga, or movement. So channeling their diagnosis and how they're dealing with their diagnosis outside of speaking to a therapist or being on medications through a psychiatrist. So that's our Sinai Infectious Disease Clinic staff in a nutshell. Next, we'll be talking about HIV routine screening and how your roles can benefit our hospital system. So HIV and AIDS are two different terminologies, but they're often used collaboratively or interchangeably in the community. It's important to understand that HIV, which is the human immunodeficiency virus, causes HIV infection. And with untreated HIV infection leads to AIDS, which is the most advanced stage of HIV and which is usually what results in death for HIV patients if they're not on treatment. HIV is deadly because it attacks and destroys the immune system, which are the CD4 fighting cells, and these are the cells that are responsible for protecting us against simple things like the flu and the cold, coronavirus. So if we don't have those fighting cells in our system, then these patients become severely sick, not just from AIDS, but from cancer and other opportunistic infections. HIV is spread through contact with mainly infected blood and vaginal and rectal fluids. So you cannot contract HIV by sharing a toilet, sharing a toothbrush, from kissing. So this is HIV is mainly spread through contact with infected blood or through sexual contact. And then ART, which is an abbreviation for antiretroviral therapy, are the medications that are used to treat HIV infection. Even though there is no cure for HIV yet, these medications are very potent, where many of our patients are able to sustain lives for many, many years, up to 90, even 100 years old nowadays. This is the epidemiology for HIV/AIDS. As you can see, more than 1.1 million people in the United States are living with HIV. But if we focus specifically in Chicago, the most frequently diagnosed age population are in the young age group, between 20 to 29 years old. And if we look at race specifically, it's highest in the African American, Blacks, and the Latinx communities. So this is very relevant to where Mount Sinai Hospital and Holy Cross Hospital are located, because these are the common population that we see in our communities. If we look at Chicago specifically, the HIV rate is 3 times the national average, which is significantly high. And that's even more so where our hospitals are located, which I'll show you in the next slide. And again, being communities of color where Mount Sinai and Holy Cross are located, we have a very high prevalence of HIV-infected patients that are come through our systems. So if you look at this demographic map, you can see anything that's shaded light blue to dark blue to red indicates high prevalence rates of HIV diagnosis in the state of Illinois. And as you can see, Mount Sinai Hospital and where Holy Cross Hospital are located, we are smack in the middle of where there's high prevalence of HIV diagnosis. So the whole purpose of presenting this presentation today is no matter what unit you are practicing in at Holy Cross or Mount Sinai Hospital, you will encounter an HIV patient, you will encounter our established patients, and we want to ensure that we'll be able to cater to whatever their needs are and link them back into care, get them back onto treatment so that they can be successful. So another reason why we're doing this presentation is for HIV screening. So everyone, regardless of who they are, what their sexual orientation is, or their sexual history is, should at least have should know their HIV status and have at least an HIV screening a year. So in 2015, Illinois passed the Illinois AIDS Confidentiality Act, and this is relevant at our hospital because as of 2015, it is a routine opt-out screening test. So instead of posing the question asking for consent for patients to get the HIV test, we're proposing that HIV testing and screening is a routine test, just as what you would get if we were checking a CBC or a CNP, making sure your kidneys are okay, your liver's okay. This is a routine test that we check on everyone who comes into our system, regardless of what their chief complaint is, regardless of what their sexual orientation is, regardless of what their sexual behavior is, and that we want to destigmatize what HIV is and destigmatize the screening test for the diagnosis of HIV. So what we recommend and we encourage to use the following script when you do meet a patient who should be screened because they haven't had a screening test is this. We offer HIV screening to all patients who come through our system. I will be drawing one today unless you decline or say no. Again, we're destigmatizing this test, making patients feel comfortable that this is a routine test that we do on everyone, and it's a routine test that's just as regular as a diabetes test, as a blood pressure test, as it is a CBC and a CMP. So unless the patient specifically says no or declines, that has to be documented. Again, you're giving the patient you're letting patients know that this is routine test instead of giving them the opportunity to say no or decline by posing a question of checking their HIV status. In terms of HIV diagnosis, the screening test, which is a preliminary test, is the HIV antigen antibody combination test. And this can be found in Meditech under immunoserology. It is a screening test, so it's very important to understand that there is the possibility for false positives. We have had many patients who were told that they were diagnosed with HIV based on the screening or preliminary test, and we don't want to do that. We want to avoid that miscommunication or that mistake. So again, it's just a screening test, and that if it does flag as reactive, that a confirmatory test, which is the multi-spot HIV1, HIV2 test, is automatically reflexed. Okay, so again, never ever give a patient a diagnosis based on the screening preliminary test, which is the HIV antigen antibody combo test. We need to wait for the confirmatory test, which is the multi-spot test. And if the multi-spot test comes back reactive, then that confirms that the patient is HIV positive. Again, we've had several scenarios where patients were positive based on their screening test, but negative on the confirmatory test, and we're given the diagnosis on that. So it's a lot of havoc that we have to, clean up afterwards, and we want to make sure that patients are not alarmed by a false screening test. Other tests that can be found, these are often found under reference labs, is the HIV RNA or viral load. This is often utilized to check in patients who are HIV positive on treatment to see if they're adherent with their medications. So again, we want to make sure we don't give patients a diagnosis based on the HIV antigen antibody combo test, because it's just a screening test that can have the possibility of false positives, and we do want to wait for the confirmatory test, which is a multi-spot test. When should one of our HIV navigators be paged is if both of these or either of these tests become positive or indeterminate. So when should we page one of our HIV navigators? Again, if any of the test results, whether it's the screening test or the confirmatory test, comes back positive or indeterminate, if a patient self-reports their HIV positive status to you, when a provider needs assistance with post-test counseling, if a HIV positive patient is not currently engaged in care or on treatment, we definitely want to involve our clinic staff so we can identify the barriers to why they haven't been following up. And again, these are for patients who can be linked into care wherever is closest to them or wherever they prefer. So the HIV navigators don't necessarily set up appointments at Sinai. If the patient prefers to go to Howard Brown, University of Chicago, Rush, or Northwestern, our navigators will do just that. They will link the patients back into care wherever it's convenient for the patient and what their preferences are. And then in Meditech, on the right-hand side, there's always a Meditech bulletin board. And so any patient that's been lost to care or patients who we've lost contact with based on incorrect phone number or telephone number will be posted in this bulletin. So if a patient is admitted back into our system, it's a sign to please page us, any of our staff members, if this patient comes back into care. The HIV Navigator pager number is 19575. You don't necessarily have to memorize this number because they are posted at each nursing station, both at Mount Sinai Hospital and Holy Cross. This pager is 24/7. Our navigators will not necessarily come into the hospital at 2 or 3 o'clock in the morning, but they will answer the page, gather the patient information, and meet the patient at bedside the following morning. And this pager navigation is for both Holy Cross and Mount Sinai Hospital. The role of the patient navigator, they're essentially the linkage for our patient from when they're admitted into the hospital to hopefully outpatient HIV care as well as treatment. Again, they offer post-test counseling, so this is not just for the patient who may be newly diagnosed or doesn't know the difference between HIV or AIDS, but they also provide counseling for family members and friends who they may disclose to. The navigators also assist with medical and prescription insurance, so if patients are uninsured or if they're undocumented or underinsured. So there is the ADAP law, or the Ryan-White law, that grants anyone who lives in the United States, whether they're documented or undocumented, with coverage for their HIV services, whether it's to see a doctor or to get treatment for free. And so there is accessibility for medical and prescription coverage for HIV positive patients, regardless of what their citizenship is. They help patients schedule ID follow-up appointments. Again, it could be at Mount Sinai Hospital or it could be at another facility, whatever is the patient's preference or what is convenient to their location. They'll meet patients at their scheduled appointments because it's a familiar face that they've seen at bedside and now transitioning to the outpatient clinic. They also make referrals for case management and mental health services based on what their needs are, whether it's transportation, housing, dental, food, and then our staff is bilingual for Spanish and English. U equals U is an important part in and hopefully ending the HIV epidemic. It's HIV undetectable equals HIV untransmittable. And so this is the science behind HIV and hopefully ending the epidemic. And so what U equals U means is a person who's HIV positive but undetectable with their virus that's controlled on treatment has less than a 1% chance of transmitting HIV through condomless sex to their HIV negative partner. Again, being on treatment, being undetectable and controlled with their HIV can really make a difference in stopping HIV transmission to their HIV negative partners. Another measure that will hopefully help end the HIV epidemic is pre-exposure prophylaxis, or PrEP, where we're using treatment as prevention. Currently, there are 2 medications that are FDA approved for HIV prevention, or PrEP, and that's Truvada and Descovy, greater than 92% effective in preventing HIV acquisition. These pills are really indicated in anyone who is having sex, but especially for those who are high risk of contracting HIV. So sexually active men who have sex with men, intravenous drug users, heterosexual men and women with multiple partners, anyone who comes to the ED with recurrent or recent sexually transmitted infections, because this is a sign of what their sexual behavior may be, and then anyone who is sexually active with an HIV positive partner. Patients who are put on PrEP, we do see them every 3 months to ensure their kidneys are okay, to ensure adherence with the medication so they don't develop resistance, and then also repeat HIV testing and STI testing. Since the advent of PrEP, we have definitely seen a decrease in the rates of HIV prevalence, but in conjunction with that, we've also seen a significant increase in STI infections. And so again, we want to make sure that PrEP prevents HIV, but it doesn't necessarily prevent against gonorrhea, chlamydia, and syphilis, and that condoms are still warranted in preventing against these STD infections. What's relevant to us here as healthcare workers is PEP, which is post-exposure prophylaxis. So there's 2 versions of PEP. There's occupational OPEP and there's non-occupational NPEP. So occupational post-exposure prophylaxis is what refers to us as healthcare providers. If we were ever exposed to HIV-infected materials, whether that could be blood, tissue, bodily fluids, contaminated equipment, or medical supplies. Non-occupational post-exposure prophylaxis, which is NPEP, refers to our sexual assault. In the emergency department, we call them code Rs, or injection drug users who share syringes and needles. So the risk of transmission for OPEP, if you are or were to be exposed to someone with HIV, is very low, but it's not negligible. The risk of obtaining or acquiring HIV from a percutaneous exposure, so needle stick, is 0.3%, and from mucous membrane exposure, so splash in an eye, a bite wound, is even lower at 0.09%. So the risk of transmission is low, but again, it's not negligible, it's not zero. The risk of transmission is even higher, though, based on the source patient. So if the source patient is indeed HIV positive, they're not on treatment, on antiretroviral therapy, they're not controlled, so they have a high viral load. The deeper the injury, obviously the more blood contact, and then how big the needle is with hollow bore needles. So the risk of transmission can be low, but there are also risk factors for higher rates of transmission. So percutaneous injury, again, refers to needle sticks, and so that's patients with where we get them through needle sticks or sharp objects. So we never want to recap needles, and then we always want to place our syringes and needles in the red sharps container. Also, any type of suturing in the OR. We also want to make sure we protect our EVS employees, so making sure that there's no sharps or broken glass or syringes or needles in the trash can. We place them all in the red sharps container. And then anyone working in the emergency department or employee health or in mental health, the behavioral unit, having restless, agitated patients can also be at risk for percutaneous injury if you're trying to get blood. And then contact with mucous membranes, so it's splashes, bite injuries, any open wounds that could be infected with blood. Again, all of these depend on how deep the wound is, if there's actual, blood exposure, or if there's any type of, the amount of blood that could be exposed to you from the source patient. So what is our protocol if you are exposed to a patient who may have been HIV positive or infected with their fluids? The first thing is to notify your supervisor or charge nurse as soon as possible. So do not wait until your lunch break. Do not wait until your patient comes back from CT. Don't wait until morning report. As soon as possible, because time is of the essence with post-exposure prophylaxis. Your charge nurse or supervisor will then send you to the emergency department, where one of the ER physicians will evaluate your injury and your risk of contracting HIV. It's very, very important to make sure you bring the source patient's name, date of birth, and MRN number with you, because most likely they will have to be tested as well. One, to confirm if they've had HIV, or two, if they are HIV confirmed, if their HIV virus is controlled on treatment by checking the HIV viral load. So please make sure you bring patient's name, date of birth, and MRN with you when you go to the emergency department for evaluation. If the ER physician deems you a candidate for post-exposure prophylaxis, then they will send you then to employee health. Employee health will write the prescriptions for you, in which you will then pick up the medications from inpatient pharmacy. Now, this protocol is valid both at Mount Sinai Hospital and Holy Cross. At the inpatient pharmacy, you will receive the medication under workman's comp. So you will not have to pay for these expensive medications. You will also receive medication counseling from the pharmacist, and then a follow-up appointment in the ID clinic 2 weeks after starting the medication. The two medications that you will receive from inpatient pharmacy, if you are going to be receiving post-exposure prophylaxis, is Icentris, which is 1 tablet taken 2 times a day, and Truvada, which is 1 tablet once a day for a total of 28 days. As you remember, Truvada we already talked about by itself. It's used for HIV prevention, for PrEP, but when it's used in combination with other HIV active drugs, it's used for the treatment of HIV. Again, time is of the essence, so we want to make sure that you get evaluated for post-exposure prophylaxis as soon as possible, ideally within 2 hours, and to get started on treatment if there is a high risk for transmission within 72 hours after exposure. We do not want to delay initiation of treatment if tests are being pending or postponed. And with that, I'll turn it over to Christopher Patron for a hepatitis C routine screening.
Hello, everyone. My name is Christopher, and the care coordinator for patients with hepatitis C, and I will explain to you what hepatitis does to the body and then what my role is here in the hospital. So first, in order for someone to contract hepatitis C, there has to be a risk behavior, and on the risk behavior, it's there could be several scenarios. It could be people that are having unprotected sex, and it could be people that are doing drugs and sharing their equipment, like things they use to snort heroin or injecting. If they share the needle with someone else. Hepatitis C is transmitted only blood-to-blood contact. So even for people that like to go get their nails done at the salon, if you have to make sure they're opening everything in front of you, that they're cleaning everything in front of you, because if they use the same equipment they use in someone else before you get there, it could be infected with blood that has hepatitis C, and that will put the risk of contracting it. Same thing with people that get tattoos. You have to make sure they're opening the needle in front of you, that they're using new ink, because even if they change the needle, if they're still using the same ink they used with the person before you, the virus is living on that ink. This virus can live outside the body up to 6 weeks, so it's very, very infectious. It's very easy to get. So once you come in contact with the blood that it's already infected, it goes into your bloodstream, and that's how the process starts into becoming an active infection. Hepatitis C is the most common bloodborne infection in the U.S. and is the primary cause of people having liver cancer. For hepatitis C, sometimes you don't get symptoms right away. It could take up to 20 years for you to get symptoms, and sometimes that could be a little bit too late because it could have progressed to cancer. So that's why it's very important for people to get tested for hepatitis C, or to ask the doctor to test them for hepatitis C, because hepatitis C sometimes is not part of the routine tests, although Mount Sinai and Holy Cross, they made it part of the routine test. If you come through the emergency room, you're going to be tested for hepatitis C, and you don't have to ask, like for HIV, you don't have to ask if they're okay by being tested for hepatitis C. It's already going to be part of the routine test as long as you're 18 years old. Between 50 to 75 for people with chronic hepatitis C, they don't know they have it. So I'm glad that Sinai and Holy Cross decided to start testing people to decrease that percentage. Some of the symptoms for hepatitis C that we see at clinic, it's abdominal pain, abdominal bloating or distension, jaundice, which is the yellowing of the eyes and the skin, nausea, vomiting, joint pain, itchy skin, loss of appetite, and weight loss. And the one that I hear the most is fatigue, excessive fatigue. But once they start taking the medication, usually the energy comes back. Why do we test for hepatitis C? Because the sooner you know that you have hepatitis C, your prognosis is going to be a lot better, because we can start you on treatment as soon as we can. So it will stop the progression of the hepatitis C and eventually becoming liver cancer. So the sooner you know you have it, the better prognosis you will have. Also, the knowledge of hepatitis C status can lead to a positive behavior change. So once you know you have hepatitis C and you know how it's spread to other people, maybe people are going to stop drinking less alcohol, maybe stop doing drugs or using less drugs, even sharing the equipment or needles with someone else to pass the virus to someone else. Also, because we also have medication, and now we have a cure for hepatitis C. You get one pill once a day. Usually it's for 2 or 3 months, but you can get cured from hepatitis C. Like I mentioned before, for hepatitis C, you don't have to have consent from the patient, because Sinai and Holy Cross included the hepatitis C test to the routine test. So anyone who's doing blood work coming through the emergency room and it's 18 years old is going to be tested for hepatitis C. The way hepatitis C is diagnosed, the doctor is going to order a hepatitis C antibody test, and there are only two results. It could be either negative or positive. If it's negative, If it comes back non-reactive, it means that the patient has never been exposed to the virus and doesn't have the hepatitis C, so the patient does not need treatment. If the hepatitis C antibody test comes back reactive, that means the patient has been exposed to the virus at one point in their life. It doesn't mean the patient has hepatitis. It only means that they've been exposed to the virus. So once it comes back positive, it will reflex into a confirmatory test, which is the HCV RNA. And also there is only two results, not detected and detected. If it's not detected, that means that the patient doesn't have a current infection and doesn't need treatment. Or it could also mean that the patient had hepatitis C and was treated and cured, and now it's not detected. But if the test is detected, that means the patient has an active infection and the patient needs to be treated. Also, once you're positive for antibodies for hepatitis C, you will always be positive for the antibodies. But once the second test comes back, and if you were treated, it's going to read not detected. Like I said, for hepatitis C, if you see a positive test for the antibody, that doesn't mean the patient has hepatitis C. That only means that the patient has been exposed. That's the preliminary test. We need to get the RNA to confirm if the patient has hepatitis C or the patient doesn't have it. 5% of the population can clear the virus on their own. So it's very important for this HCV RNA test to be ordered if the antibody is positive. You will find this test on Meditech on the reference labs. When should you page the hepatitis C navigator? When the patient's HCV antibody is reactive, also when the patient's HCV RNA is detected. Even if the hepatitis C RNA is not back, as soon as you have the antibody test reactive result back, you should page the navigator because the confirmatory test, which is the RNA, takes about 3 to 5 days, and usually the patient is not in the hospital for that long. So I need to see the patient as soon as the antibody test comes back positive, so I can get a good phone number and address and maybe make them an appointment if they know they have hepatitis C. Also, if the patient tells you at bedside they have hepatitis C, and that happens a lot, they will let you know they have hepatitis C. Just page me, and I will arrange either for them to come to Sinai to get treated or to go back to whatever doctor they've been seeing for hepatitis C. If the doctor needs assistance with post-test counseling, I can do that as well. If the patient has hepatitis C and is not receiving treatment, I can link him to a doctor to start him on treatment. If there is a bulletin note on the right side on Meditech, that means that the patient has been lost to care, either because I didn't have a good phone number or because the address doesn't work. So I will put a note saying, please page the patient navigator so I can link the patient back to care. The pager for the Hep C navigator, it's 16464, and you can page me any time and any day of the week. The hepatitis C treatment, it's a lot better than what it used to be. Before, people used to inject in their stomach, and it was for about a year, and it was only 50% chances of them getting cured, and some of the side effects were really bad. I have seen some patients that started the treatment, took it for only about 3 months, 6 months. Some of them even completed the treatment, but they did not get cured, and some of them stopped because of the symptoms. But now the medication that we have is really good. You take medication, one pill once a day for about 3 months or 6 months, depending on what the doctor says, and patients get cured from hepatitis C. Medication is very expensive. It's about $90,000. Every pill is about $1,000, and you have to take it every day for about 3 months. But the cure rates are greater than 95%. So these are some of the people that we work with. We have Bijo Hunt, who's our program director, Justina Sims, who's the program manager, and this is one of the doctors, Dr. Nancy Glick. She has an afternoon clinic on Thursdays afternoon in the Schwab building on the first floor. This is the information for our clinic, the Sinai Infectious Disease Center. at 1414 South Fairfield Avenue, across the street from Mount Sinai. The phone number is 773-565-3230. And our receptionist's name is Laura. Just in case if you call that number, Laura is going to be the one answering the call. The clinics are Monday, Wednesday, Friday, and Thursday afternoon. Thank you and have a good day.